I actually first signed up as a consultant in Newcastle on iWGC's in about 2008. I found it on the internet, I signed up, I had no idea what to do with it. As my career started shifting away from my area of clinical expertise, went to work with a team that was in a really distressed state. One of the things that I asked that clinical team was, okay, so there's all this pain here, I want you to convince me that you're generating good quality care regardless of all this madness that's around you. And of course, as doctors would say, they say, clinical care is not a problem. That's never going to be a problem. It's all this other madness we want sorted. And of course, you and I know that's never true. A broken team will not generate good quality care for patients. That's a given. So I challenged that team and said, okay, here's a way you could transparently show me regularly what you're doing with your patients and your families. And I knew some of my colleagues in that team had some behaviour issues in terms of how they interacted with colleagues and staff, so I worried about how they interacted with patients and families, rightly so. So there was variable engagement, but what was striking was there were some real go-getters got on with it and said, right, we'll do this, and there were some that were kind of reluctant but went on it, and some I had to work with. But it was really tangible for me to see their behaviour shift during that job that I was doing with them. Because that allowed me, amongst other things, for them to focus on why they came to work, which was about patients, which was about caring for patients. It was about the stuff they do in clinic and on the wards. And that if they realised that that's why they came to work, then I could work with them on all this other madness a bit more easily. We have been forced to be transparent because of the NHS history around catastrophic stories is the one way to describe it. So if you remember from the Bristol story, along came the transparency required on cardiac surgery. And now every surgeon, if you go to NHS Choices, you can look up any surgeon in terms of their outcomes. Patients can access that today. So the transparency shift is really astounding, and I believe a good thing. Now my physician colleagues will think, oh, we're okay because you can't measure us. Trust me, you can be measured. And I'll say this again and again. Either you measure yourself or you will be measured. So I know where I'd like to be. When we send out an appointment to see a consultant clinic, I'm sure I would, and others would, look up that person on the internet. And if you look at my profile, the second busiest thing after Twitter is, I want great care for me. You'll then go to I want great care and you'll see what other patients have said about me. So before you get into clinic, you've already got a sense of who you're coming to see based on what other people said. But there is an issue around negative feedback. And my duty as a medical director with my colleagues is to provide the support that colleagues require when they get negative feedback, rather than use it for anything else. The problem with the CQC annual retrospective review feedback, which is done in 2015, and I get the report almost a year later, is it's too late. It's way too late. And it's collected in retrospect and not clinician or facility specific. I can't act on it, I can't make a difference, except it's a regulator determined, regulator important piece of information. And they use that, don't they, to determine their sense of the organisation, even if it's a year out. And of course, it's my duty to actually work with my colleagues to say, we've got to find a different way of shifting how a patient experience is experienced, not only how we measure it, but how we respond back to the clinicians when things don't work out. And the reason I like I Want Great Care is because I think it's simple. It's really simple. 3 questions, narrative, and easy for patients. It actually does affect behaviour without you having to do much more than asking for that transparency and honesty in the work they do every day. That knowledge is now out there, it's seeped out, which has blurred that sense of protection that the professions had through their colleges acting as barriers. But actually, regardless of the outcome, be it good, bad, or indifferent, the patient will always remember the experience. So even when the outcome is inevitably going to be poor, and the experience provided is poor, we are all indeed troubled, and rightly so. But even if you provide good clinical outcomes and provide a poor experience, they will remember the experience. I know that. They'll come out and go, yeah, that's fine, but here's no bedside manner. So as doctors, I think we better figure out what our value is, actually. Because if we can automate medical knowledge, which we can, and they've proved it, and they're proving it every day, then we better find out why we exist and what we exist to do, other than transact the operation, the dialysis, or the drug. And that's me.